This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on dementia prevention in patients with heart disease. And with me, we have a special guest, Dr. Louis Bherer, professeur du département de médecine à l'Université de Montréal, titulaire de la chaire de recherche Mirella et Lino Saputo en santé cardiovasculaire et prévention des troubles cognitifs. Il est aussi chercheur au centre EPIC de l'Institut. Il est chercheur et directeur de laboratoire à l'Institut universitaire de gériatrie de Montréal. Alors Louis, merci beaucoup de faire partie de ce podcast sur la prévention de la démence.
Thank you for inviting me.
Yeah. We know that the number of older people, including those living with dementia, is rising as the younger age mortality is declining. Worldwide, around 50 million people live with dementia, and this number is projected to triple in the next 30 years. Dementia affects individuals, their family, and the economy, with a global cost estimated at approximately $1 trillion. It is believed that more than 40% of dementia cases can be prevented by addressing the risk factors. In 2017, the Lancet Commission identified 9 modifiable risk factors that included low education, midlife hearing loss, obesity, hypertension, late life depression, smoking, physical inactivity, diabetes, and social isolation. Over the last few years, the age-specific incidence of dementia has improved in many countries, probably because of improvement in education, nutrition, healthcare, and some lifestyle changes. In 2020, the Lancet Commission has reconvened and has identified 3 more modifiable risk factors, and that is excessive alcohol consumption, traumatic brain injury, and air pollution. So the Commission has adopted a new life course model where it is never too early or never too late for dementia prevention. They recommended keeping cognitively, physically, and socially active in midlife and later life. And today we'll discuss with Dr. Bherer some of the evidence demonstrated in his research that we can actually affect and prevent dementia. So, Louis, if you could really start at the beginning and see if you could define for us dementia, and also if you could define this syndrome of mild cognitive impairment, and particularly what common cognitive deficit do we find in our patients with cardiovascular disease? Louis.
Okay. Sure. I'll start with the definition of MCI and dementia, and then I'll slowly go to what type of deficits we see in patients with cardiovascular disease or cardiac diseases. So mild cognitive impairment is this stage of disease where you have some sort of cognitive deficits that are not strong enough to impact your everyday life. But most people will take note of these deficits. You have noticeable changes that you pick up as a person, or maybe it's your wife or your friends. You start to forget some specific items. You forget when you've put things. Sometimes it impacts judgment as well, but not strong enough so that your life is impaired. But it's annoying, and it comes with anxiety sometimes. We would say there's 2 types of, there's multiple types, but there's 2 main types of MCI or mild cognitive impairments. The first one is the amnestic MCI. That's the one that impacts most memory, right? And we believe these patients are those that will have their higher risk of progressing towards dementia. The other type of MCI is the non-amnestic or the non-memory based MCI, if you will, where we see people complaining about thinking, problem solving, attention. They tend to be less attentive. I have slowing cognitive processes as well. They are less associated with the progression of towards typical dementia because they're less, concerned with memory. But they're mostly those that we see with patients that have cardiovascular disease. They tend to be less executive in nature, so they have a harder time to control their memory, to control their attention. They report confusion sometimes. But again, it's an early stage. We cannot be sure that patients will progress towards dementia. As a matter of fact, some statistic will put the chances towards 40-50% maybe of those patients with amnestic MCI that will progress towards dementia, which means that there's a great proportion of those people will not develop dementia. Now, dementia is way more important and would come with not only measurable deficits, but deficits that will impact the day-to-day of the person. Without going into the very technical medical diagnostics, if you go and look for at the Alzheimer's Society website, for example, they'll give you tips to identify what is really dementia and how it impacts real life. And in many instances, they will give you like 8 to 10 big symptoms or items to keep in mind to see if you're dealing with dementia or your loved one is dealing with dementia. And the first one thing to look at is, of course, memory deficits. That the big I would say hallmark of dementia, but it doesn't always start with memory deficit. Sometimes it starts with attention deficit, anxiety, slow processing of thought, for example. But eventually, memory loss is a big part of dementia. It comes with difficulty to completing cognitive task or day-to-day task. We see a lot of confusion as well in time and place. So people get lost in time. They need a calendar to remember what day it is. They do have problem to understand as well. So problem solving, jokes, for example, they get confused when you make jokes. It sometimes comes with a poor judgment as well. Poor judgment, poor decision making, change in mood and personality. And of course, all this has to be strong or important enough to have an impact in daily life. So we talk about dementia when, or now more strictly speaking, about severe cognitive deficits when it has an impact on the daily life of the individual. So the person cannot keep up with work schedule or cannot complete his tax reports, for example, and cannot take care of him or herself. So that's the big dissociation between MCI and dementia. Now, MCI, sometimes people will stabilize or can even reverse. And by definition, dementia is a progressive disease. So we talk about dementia when there's no way back, so to speak. So of course, it's a diagnostic that will take years to establish, right? You cannot just test a person in a given moment in time and say, okay, this is dementia. You have to test this person on several occasions and see the person again. So a typical recommendation for patients with MCI is to give, of course, tricks to help, manage all these deficits. But most importantly is to see this person again in 6 months' time to see if there's some sort of evolution in the disease. And if there's no evolution, then it's probably not dementia. It's probably something else.
I find as a physician, it's sometimes very difficult to kind of, you see that patient just every 6 months or sometimes on a yearly basis. A lot of times the schedule is very busy. You may see, 25, 30 patients a day, and some of the family physician even more. And it's very difficult to kind of clue in, on some of these deficits unless they're very obvious. And it looks like by that time, maybe too late. And it's so often the family and the spouse that really kind of notice, or sometimes the friends, that come with that patient that can really notice some change. That they're not doing the gardening so much anymore. Or sometimes I see some of the elderly patients, they're starting to have some motor skill issue. I mean, they're having problem with balance, and sometimes they're starting to fall. The memory is maybe not so good. I mean, is this part of this picture of dementia overall? This kind of not only cognitive but kind of neuromotor.
Yeah. Well, definitely, there's an increasing interest in those patients that show both type of deficits. We know some patients will start with more moderate deficits or more moderate symptoms, and some others will show what we refer to as we call them the dual decliners, because they have both the motor deficits and the cognitive deficit. And as a matter of fact, there's some studies suggesting that if you have both type of deficits, you have a significantly increased chance of progressing towards dementia and at a faster rate. So you're right. The deficits in mobility in general, but just walking speed. A change in walking speed is a sign that could be associated with a progression to dementia. And it goes in line with, and we can talk about it later, it goes in line with why there's so much interest now on keeping people active so that you maintain both, not only cognition, but also motor function as much as you can. Because, in some profile will come up with these change. And as you nicely said, it's very important to keep in mind that these symptoms have to occur in a recent history in the lifetime of a person. So there's something that changed over 1 or 2 years in most people that have dementia. It's something that occurs slowly, but that definitely has been noticed at some point by the environment, the family, the husband, the wife. And sometimes it comes with less cognitive deficit, but sometimes mood deficit, like people are, would tell you like, okay, she was active, she used to walk every day, but now she's not motivated to walk anymore. And or he always talk about depressing stories, and that's not him. That's new, But again, it has to be marked by a change. If the person was like that for all his life, that's different. It's a different type of problem that we're not going to talk about today.
Well, it's for sure that particularly in the field of cognitive deficit, the family is really part of the team. As a physician, I think it's very difficult to perceive unless it's very radical, or unless you start, seeing patients requiring more and more frequent hospitalization. It seems like to have some kind of relationship, and particularly during that hospitalization, they get this syndrome of sundowning, where they're totally decompensated in a different milieu or environment. And I guess the best thing we could do as physician is to really kind of focus on the risk factors for all of our patients, coming to see us in the elderly, mostly, making sure that their blood pressure is well controlled and their diabetes is also, in check with, good control of their glucose, and encourage the patient to exercise on a regular basis. I think as a general, kind of prevention measure for a busy physician in the office, that's probably the best that we can do. But now let's talk about really what you focus all of your research and your effort on, and maybe you could explain to us what lifestyle intervention, including the cardiac rehab, what does it have on the brain structure and the brain function?
Yeah. Well, first, before we go there, I'm just going to want to start with one thing that you just mentioned is, the importance of prevention is everywhere right now. And one of the things you just said is one way to prevent dementia is to try to control all those cardiovascular risk factors that patients have. So that's the core of prevention, and that's the core of the research we're doing. But the rationale here is that we know now, and we've known that for a while, and certainly doctors who see patients know that because by experience. You mentioned glucose. All the other risk factors are associated with a certain level of risk of cognitive deficits. Hypertension, for example, sedentarity or physical inactivity, smoking, obesity. All those risk factors individually and together will predict some risk of cognitive deficits. That we've known for a while. And, you just have to look at the super well-known Framingham studies, and all these sub-studies that came out from this big initiative, showing that as you accumulate risk factor, which is often the case in a patient, if you have diabetes, but you also have hypertension, you also have a big, BMI, for example, or a person who's smoking as well. So you have 2, 3, or 4 risk factor. The level of impairment that we can see in these patients is higher than those that have fewer risk factor. So, of course, that opens the door to the prevention initiative. You can see that, that those factors, if you can help patients maintain these factors away, you will reduce not only the risk of having right now a cognitive deficit, but also to evolve towards MCI and dementia. And that's been known in large cohort studies for a while. And you've mentioned the prevention paper by Livingston that was published again this year, the Lancet Commission. It's pretty much what they summarize in this paper, right? They summarize this old big cohort study of 20,000 patients that have been followed over and over again. But what we really do need now, and that's what we're trying to do in our research, is to see if we take someone here and now and change his lifestyle, will we see, like in a short amount of time, an increased cognitive processing, reduced deficit, and a better ability to maintain these functions for a long time period, or to prevent them from developing MCI. And when you look at the literature out there, there's not that many studies showing with strong evidence that controlling all these factors will reduce the risk of dementia. So that's pretty much what we're trying to do. And in normal patients or normal people who have some level of cardiovascular risk factor, but they don't have like a diagnostic of cardiac disease, we refer to it as a preventive strategy, right? A primary prevention strategy in our world of brain function, so to speak, because they don't have any brain diseases. But for cardiac patients, of course, we integrate these interventions into the cardiac rehab process, because these patients in many states and provinces, they have the right to have a certain level of cardiac rehab program. Now, it's not the same in all provinces and states, I suppose, in the US, and it also depends on the accessibility of these centers. So sometimes we can't really have the whole setup. But if you could, the best way to prevent cognitive deficits in these patients is to have them engaged in 3-4 times of exercise a week and a certain level of cognitive stimulation as well. And that's pretty much the studies we're trying to run right now, where we will randomize people that just came out from the emergency room because they had a procedure and they've been diagnosed as coronary patients or at a cardiac surgery, and we will randomize them to a cardiac rehab program or a cardiac rehab program in addition to cognitive stimulation, in addition to social interaction, and try to see if all these factors together can boost cognition enough and help them maintain higher level of cognitive processing. Because we know, that's a fact that's been published many, many times, that patients with cardiac disease, and even before patients with cardiovascular risk factor, have higher risk of showing deficits as we see in MCI patient. As a matter of fact, for heart failure patient, it goes high to, as up as 60% of them will show MCI, and eventually have twofold risk of developing dementia. So 2 times more risk of developing dementia than people of the same age who don't have heart failure.
And Louis, this is because of atherosclerosis, plaque emboli. Patients have intermittent AFib and they get these microemboli or small clots going to the brain, or
that's part of the story. There's also hypoperfusion, like their brain is less infused with oxygen and glucose because the blood flow is reduced. Eventually what we see is, and it's hard, of course, to know what comes first and second, but what we see a lot in patients even with cardiovascular risk factor, not even like heart disease and heart failure, but just these patients that have diabetes, hypertension or a couple of those factors. They have reduced brain volume, reduced brain blood fluid in the brain. They have what we call white matter hyperintensity, which is supposed to refer to some sort of microvascular diseases in the brain, and it comes up in a scan as a white color, so that's why we call white matter hyperintensity.
Mostly in hypertension.
It's a lot in hypertension, but also in patients with diabetes, and also in patients obese people tend to show that more than non-obese people as well. So as it increases with the number of risk factors. So and another very important aspect of these is also the moment at which it occurred in the lifetime of a person. So for example, if you take hypertension, middle-age hypertension is bad. We know that. Late life hypertension is less bad than middle-age hypertension. And that's true for the brain as well. So if you're 50, you're hypertensive, you must control it as much as you can and as fast as you can. If you've never had hypertension and you develop it at 80 years old, well, that's a different story. And we know it has less of an impact on the brain. But, so the time of onset is extremely important. And the number of disease the person has is extremely important as well. So, I mean, it's a simple mathematics, right? The longer you can push it, and the less and the most you can control it is the best. And
it probably works exponentially, like we see with the risk factors, additive and exponential. So, I mean, there are some trials that are being conducted, multi-center trial, trying to intervene, but the results have been kind of like underwhelming, haven't they? I mean, is it because it's too short duration or too short follow-up to see the difference in the clinical trial, to affect the cognitive deficits or not? Or
well, there's extreme diversity between studies. Like a lot of studies, it's rare to see studies that have the exact volume of exercise, for example, than others. Or there's a big trend right now to do what we call multi-domain intervention, right? In which patients will have an exercise program, a nutrition program, some sort of cognitive stimulation, social engagement intervention. But in each of these domains, we lack studies to showing us what exactly is the dose response, right? So we're like merging many, many fields, to me, in a way that well, first, it's too fast, it's too quick. Because for every one of those studies, we don't know exactly what we should do. Just take exercise, for example. Well, first, it's quite new in the history of science that we now use exercise as a way to boost cognition when you think about it, right? It's always been suggested, but it's a different trend right now. We're actually prescribing exercise to people. It's very different. Now, as a physician, what type of exercise would you prescribe and how long? It remains an open question. And I give a lot of talk to physician association, and sometimes I would stop and ask that. And it's impressive how few people will try and answer, and some would say, okay, aerobic exercise 3 times a week. Of course, that's the recommendation. But I have studies, and from many other labs, including myself, showing that strength training exercise also boosts cognition. And it also shows not only cognitive changes, but also brain function changes as assessed with MRI. It also shows increased circulation of BDNF, those protein that calls for neurogeneration, okay, or those cascade of improvement in brain plasticity, so to speak. So if you do strength training in animal and human, you increase that, which means that even in that domain, that's exercise, you should have a multiple approach, right? Whereby you do aerobic exercise, but also strength training exercise and mobility exercise as well, because we know mobility exercise has an impact as well. Now, if you do multi-domain intervention, chances are you won't have enough time for each this domain to be complete enough or comprehensive enough to have all those type of intervention. I'm not an expert in nutrition, but someone would probably tell me the exact same thing with nutrition. I can tell you that for cognition, I've worked in that domain for a while, and I know that just speed training is not enough. You need to do speed training, executive control training, learn some memory tricks or memory strategies as well. So again, in this domain, you have multiple interventions that you should be doing. Now, as I'm talking, you probably think, okay, so is that a full-time job I'm supposed to engage in, Because if I have to train 10 hours a week, and do memory exercise every day, that's a whole complete engagement, and nobody, honestly, I would challenge anyone to give you a very precise answer of a dose response right now that we know will have not only boost cognition for a while, but have a true impact on the long time run to prevent dementia. And that's the big thing people are trying to do right now. And that's why we need more study. We need large study, multi-center, multi-country studies. But before going there, we need a little bit more of an agreement on what are those ingredients in any domain that should be part of this intervention.
Louis, didn't you publish some studies that looked at the level, the type of exercise, of showing that the aerobic type of exercise and a good effort, a moderate to strong effort really makes a difference, more so than strength training, more so than stretching, and then maybe a bit more so than the the yoga or something? Or is there kind of like a level? One does more than the others, but obviously together could be really.
I think they do different things, and of course, first they have different impact on brain function. We know that aerobic exercise is key. You need to have a minimum of aerobic exercise. I'm pretty sure every expert would tell you that, and that's even more true if the person is untrained, because that's another important aspect. What's the baseline are we talking about? If someone is obese, very untrained, and I shouldn't say obese because we have a study we just published this year showing that even obese individuals, if they're trained, they don't show the typical deficits that you see in obese patients. And I'm talking cognitive deficits. And the paper is entitled "Obese but Fit." So it's easy. You can Google it. And
are they the one to benefit the most? Actually, the one that needed the most? No?
Not always. But what's important here is that even if you're hypertensive and obese, your cognition is likely to improve with exercise. Even though you're still obese at the end of the program. That's the point. So you don't have to be fit and slim, and you don't have to look like an athlete. You just have to exercise. As much you exercise, as much there's going to be an improvement in cognition. That we know that, whatever is your baseline condition. But you have to have a minimum of aerobic exercise, I would say. Now, if you just do aerobic exercise, you don't have all the benefits that you would have if you combine it with strength training exercise and a good level of strength training exercise. I'm not talking here just like that typical 5 minutes of strength training at the end of your running session. And it really has to be a substantial strength training exercise. And there's also studies out there showing that yoga and motor control exercise by themselves, without aerobic exercise, will lead to improvement in cognition. So chances are that all those type of interventions are, using different paths or different biological cascade to have an impact on cognition. And I'm not going to try to explain to you why right now, but we have data that show that they do have an impact by themselves. So
how do they actually modify brain structure?
They do. So there's data showing that you have on the long run, people that do exercise on a regular basis will have higher brain volume. And that's typically true for a very specific region. And it's been shown by at least one or two clinical trials, one of which was run in the US at the Beckman Institute, was published by Kirk Erickson several years ago now, showing that after a year of aerobic exercise 3 times a week, sedentary patients showed improvement in the hippocampus volume. The hippocampus is this very key brain regions that's involved in memory processing. And it's not only involved in memory processing, it's also the key regions that show the strongest atrophy in patients with Alzheimer's disease. So, here you have a good example. That's one study, but still you have a very good example showing that aerobic exercise on a regular basis, we're talking a full year of training here, showing an improvement, a significant improvement in the key brain regions that's involved in memory, which is the key symptom of dementia. And the control group, who I believe was doing stretching, the same amount of time, but just stretching, no aerobic exercise, did show the typical atrophy or brain volume loss over 1 year. Because typically after 50, 55 years old, we lose brain volume. And in this specific study, the people who were doing aerobic exercise didn't show that loss. So, there's hope. I mean, that's, again, one study, but if it is to be reproduced many, many times, we'll be able to see in different occasions and situations and countries, maybe, and different type of exercise, maybe, that this is, one key domain that we should look at very seriously to reverse cognitive deficits as we age.
It does also affect the function. So how do you measure in your studies and your clinical trials, how do you actually measure brain function, Louis?
So brain function, well, typically we would measure it by, combining global cognitive measurements that we typically use in clinic, like, the MMSE, the Mini Mental State Assessment, or the MoCA, the Montreal Cognitive Assessment, just to have a clinical standard, but adding to it a full neuropsychological exam. The neuropsychological exam will look at the different domain of cognition, and it will include speed of processing, memory, of course, but not only long-term memory, as we typically refer to memory as being, episodic memory. We're asking people what, learning a bunch of words that are not associated together and trying to ask people to remember those words. And 20 minutes later, we ask them to remember the words. That would be episodic memory. But we also look at what we call short-term and working memory. So the ability to control the items that you have in memory. If I give you a set of words, but I'm asking you to repeat them following the alphabetic order of the first letter of the words, for example. So that you can imagine the mental ability you need to call upon to do that kind of task. A patient that shows the beginning of an MCI or some sort of deficits will have a hard time. It's a bit like a stress test for cognition, so to speak, right? You ask them to be away from that comfort zone, to do some sort of cognitive processing with non-automatic, I would say, answer, for example. So they've never seen the material. They have to learn it. They have to manipulate it. They have to give you answer based on your instruction. So that would be the way. And of course, you can come up with all sorts of tests. There's clinical tests that have norms, and so that your performance can be compared to patients of the same age and the same background. But there's also a lot of experimental work that is going on right now to try to develop more fine-grained analysis of the cognitive functioning of the patients.
We mentioned that the exercise really kind of helps, and there's different types of dementia. Obviously, Alzheimer dementia being the most important one, but in cardiology, we see a lot of vascular dementia. So is it the thinking that the exercise helps primarily this type of vascular microangiopathy kind of dementia, or does it really matter?
Surprisingly, I'd say no. I don't feel that exercise is being used more for people with vascular dementia. I think that there's a huge hope of using that type of approach with both patients, Alzheimer's disease patient or more typical dementia and vascular dementia. Now, that makes sense because, the link between vascular disease and dementia goes back to a long history when you think about it. And Alzheimer himself, more than 100 years ago, when he was reporting on his first patient, AD, Auguste Deter, was reporting at postmortem after examining his brain, referred to a very specific observation at that time. He said that he saw hardening of the arteries in the patient, right? So we're talking more than 100 years ago, where dementia had some association with vascular impairments, so to speak, in the brain. Now, all sorts of things happen in research. There was the genetic revolution at some point. People were looking and are still looking for genes that, together will be able to predict who will develop dementia or not. And it's fascinating to see that over the last couple of years and maybe last decade, it's coming back now. There's an overlap. We know that not only vascular patients will have higher chance of developing dementia, but demented people when you look back, have more vascular diseases as well. So there is definitely an overlap. And I'm not just talking here of vascular dementia. I'm also talking about Alzheimer's disease as well. So there's an overlap, a huge overlap between the two diseases that co-occur. It's hard to know why and how it develops, but in all dementia types, there are some sort of vascular malfunctions, if you will. So, I'm not a pathologist. I will not start trying to explain this, but this is an observation we can make in clinic a lot. And so that's probably why exercise, which typically is used in cardiac rehab to target, cardiovascular disease, works as well for preventing dementia, and not just vascular dementia, but all types of dementia. So
this is fascinating. Thank you so much. We'll take a break, and when we come back, we'll talk about we're going to transport ourselves to the Montreal Heart Institute and discuss this multi-domain intervention that you're doing.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.